question, we will go ahead and do that. Hi everyone, I'm Holly, the Program Service Coordinator at the Chromosome 18 Registry and Research Society. We're so happy you're here with us. We hope you are enjoying the conference so far. Dr. Niolet has a great presentation coming up in just a few minutes. We will type a few links into the chat box if you're interested in silent auction, merchandise, you're interested in a family table. We will put those links into the chat. And I do have a quick intro on Dr. Paul. So Dr. Paul is board certified in allergy and immunology. He completed his residency in internal medicine and pediatrics. Let's see. Much of his training was performed at the Children's Hospital, which is a Jeffrey Modell Diagnostic Center for primary immunodeficiency. The goal of these centers is to increase awareness of primary immunodeficiency and to offer early screening and diagnosis of PI. That was a mouthful.
Yes, it is.
Dr. Niolet is originally from New Orleans and has lived on the Mississippi Gulf Coast since 2007. He holds appointments at Ocean Springs Hospital and Singing River Hospital. He, along with his wife, Carrie, who might be tuning in, are proud parents of 2 daughters, 17 and 14, and a son, Louis, 12, who has 18P minus. We are so excited to have you with us, Dr. Niolet. We're really looking forward to your presentation. Thank you so much for being with us. And without further ado, we will turn it over to you.
Well, thank you for that introduction, Holly. Like you said, I'm practice allergy and immunology in Ocean Springs and Biloxi, Mississippi. You can go to the next slide. I have no disclosures. I am not affiliated with any of the pharmaceutical or research companies that had anything to do with the development of these vaccines. Next slide. So this is a picture of 2 boys who were exposed to smallpox at the same time. The boy on the right had been vaccinated earlier in childhood against smallpox, and the boy on the left did not. The vaccinated boy actually developed a few lesions on his forehead, whereas the unvaccinated child had disseminated smallpox. Next slide. So variola is the virus that causes the disease smallpox. It had been around a long time. It conferred a 30% mortality rate, and of those who survived the infection, they were often left with many scars over their body from the pox lesions. Next slide. So it was noticed that people who were infected with cowpox, which is a virus that's similar to variola, developed a few lesions, typically had very mild disease, but they were at less risk for developing smallpox. And in 1774, England, a farmer named Benjamin Jesty is credited as being the first person to inoculate someone to prevent smallpox. So he actually took material from his own cowpox lesions and inoculated his wife and his children with that material. And when the smallpox epidemic came to their town, they survived and did not contract smallpox. And so his wife made sure to place that, that note of history that her husband was the first person to prevent smallpox by vaccination with cowpox. Next slide. But Dr. Edward Jenner is the scientist that we credit with bringing this vaccine to the masses, and this in fact was the first vaccine. So he had noticed that milkmaids who had been exposed to cowpox and developed few lesions were at less risk to get smallpox. In 1796, he inoculated the 9-year-old son of his gardener with material from a cowpox sore on one of his milkmaid's hands. He then exposed that boy to variola on multiple occasions, and he did not develop smallpox. And in 1801, Dr. Jenner published his data that vaccination with cowpox can prevent infection with variola and the disease smallpox. Initially, the vaccine was met with a lot of hesitancy and doubt, but as time went on, it was quite obvious that the vaccine was very effective, and there became a large push to rid the world of variola, and mass vaccination was successful, and about 200 years later, in 1978, the last known case of death caused by variola virus occurred in England. The virus is thought to be eradicated from the earth, except for a few military laboratories who still research the virus to this day. Next slide. So in December 2019, the world became aware that there was a new coronavirus started in Wuhan, China. The illness was referred to as COVID-19. The first positive cases were reported in the United States, and by March, the next month, all 50 states and territories had reported positive cases of COVID-19. Next slide. So the coronavirus is unique in that it has a spike protein over the viral capsid. And if you look at it under an electron microscope like this image depicts, it appears to be like the sun and rays from the sun, hence the name coronavirus. Next slide. It's transmitted through inhalation of respiratory droplets and aerosols. Also, if someone were to cough or sneeze on you and deposit the virus onto your mucous membranes, and then also contact with infected mucous membranes, and less likely, but it's possible, inanimate objects can also confer transmission. Both the SARS-CoV-1 and SARS-CoV-2 viruses attach to different receptors than most alpha coronaviruses do, and that's called the ACE2 receptor, which is predominant in the respiratory epithelium. Next slide. Symptoms of acute COVID-19 include systemic fever and chills are the most common, followed by muscle aches and fatigue. Respiratory symptoms, especially cough and shortness of breath, which leads to a major part of the mortality from this disease. And the virus has a unique ability to cause decreased sense of smell and taste that may be long-lasting in some. It can also cause gastrointestinal symptoms. Next slide. So about 20% of all people infected will require hospitalization. There are comorbidities that increase this risk of hospitalization. These are in descending order. The most severe comorbidity is severe obesity, followed by chronic kidney disease, diabetes, obesity, hypertension, then asthma. Initially, we were very worried that people with asthma would be at high risk for hospitalization as it's a respiratory virus. But it turns out that hasn't been the case. It's one of those mysteries with this virus, but although asthma is a risk factor of hospitalization, most people with asthma who contract COVID-19 do quite well. Age is also a risk factor for hospitalization, more than 65, but even the 45 to 64-year-old demographic are more increased risk for hospitalization than the younger adults. And African American males are the most likely to be hospitalized. Next slide. So in addition to the acute symptoms that people have with the infection, there are long-term symptoms that some people develop. Now, this is a study that was recently published from Norway. It's about 300 adult patients, young males and females. 61% had reported long-term effects 6 months after infection. The most common was loss of sense of smell and taste, followed by fatigue, shortness of breath, difficulty concentrating, and then memory problems. Next slide. So now we get to vaccine development for COVID-19. Next slide. So this is a busy slide that shows how the immune response works in the setting of vaccines and infection. Your B cell lymphocytes produce proteins called antibodies or immunoglobulins. Those antibodies attach to the surface of viruses and bacteria, and they target those cells to be killed by your immune cells. In some infections, as is the case with COVID-19, T cells are very important at directing your B cells to make a more robust antibody response as well as a more specific antibody response. Next slide. So, and that is how the mRNA vaccines work. So mRNA technology has been around for approximately 18 years, but these are the first vaccines that we've developed that use this technology. So mRNA is injected, your cells will absorb that mRNA, which goes to the ribosome and is translated into proteins. In this case, it is the spike protein on the outside surface of SARS-CoV-2. That spike protein is then secreted by your cells and your immune cells foreign, and the antibody response is made to that protection from infection with this virus. Next slide. So these are the vaccines that are currently available in the United States. We have 2 mRNA vaccines, currently commonly referred to as Pfizer. Pfizer is currently approved for 12 and above, and it's 2 injections given 3 weeks apart. Mrna is approved for 18 and above, 2 injections 4 weeks apart. And we also have a viral vector vaccine, which is the Johnson & Johnson vaccine. It's currently 18 and above, and it's a single injection. Next slide. So vector vaccines are replicating human or primate adenovirus is a virus that causes upper respiratory infection, colds in people as well as primates. The adenovirus cannot reproduce, and a gene has been inserted for that spike protein for COVID-19. Spike protein is displayed on the surface of this adenovirus, elicits an antibody response. It does require a high dose of virus to be given since the virus. So there are 3 viral vector vaccines that are available in the US. Only the Johnson & Johnson is available, but also Oxford AstraZeneca and the Russian Sputnik 5 use this technology. Next slide. So there's also another vaccine in development. This is currently in phase 3 trials, and that's the Novovax Vaccine. This is a recombinant protein vaccine. So they've taken the spike protein and attached it to a nanoparticle, which stimulates an immune response. And so far, the data in the phase 3 trials looks very promising. This actually looks to be as effective as the mRNA vaccines. Next slide. So where are we at right now? Total diagnosed infections is over 33 million. And of course, we know many more people have been infected with this virus than have been tested. Total deaths are above 600,000, which initially 80,000 was thought to be kind of the ceiling of this, and we've long surpassed that. Fully vaccinated right now, about 47% of the US population is fully vaccinated as of earlier this month. Next slide. So how effective are these vaccines? Well, the mRNA vaccines are both very effective, and this is data from the phase 3 trials. They were both about 95% effective at preventing getting the disease, and they were 100% effective at preventing hospitalizations and severe disease from COVID-19. Now, no vaccine is going to be 100%, and we know that, but they do appear very effective, and in fact, they're a lot more effective than, say, the flu vaccine. The Johnson & Johnson vaccine was about 66% effective at preventing infection, and then it was 93% after 2 weeks and 100% effective after 4 weeks of getting the vaccine at preventing severe disease and hospitalization. Next slide. So I initially did a Facebook Live talk about vaccines at the beginning of the year, and there were a lot of questions from the Chromosome 18 registry about antibody deficiency. And so antibody deficiency is the most common immune deficiency associated with chromosome 18 abnormalities. We do not recommend to give live virus vaccines to the immune deficient patients. So that would include the viral vector vaccines like the Johnson & Johnson, AstraZeneca, Sputnik 5. But the mRNA vaccines have been shown to be capable of producing positive antibody responses, even in people who have antibody deficiencies. So people with antibody deficiency often aren't able to respond to certain types of vaccines and infections, and those usually typically include the polysaccharide vaccines. Well, the mRNA vaccine produces a protein, and of my patients that have antibody deficiency and on IgG replacement, of the ones that have gotten vaccinated and I've checked their antibody response, they are positive 100% across the board. So they are making antibodies to the spike protein and should be protected against future infection from the virus. Next slide. So in the initial stages of the vaccines released to the public, there's a lot of concern about allergy and having a history of allergy, specifically to foods like shellfish, peanut, tree nuts, but also venom, pet allergy, environmental, and latex allergy. And would that increase your risk factor of being allergic to the vaccine? And in fact, that really has not played out. So of my patients who have a history of any of these allergies that have gotten vaccinated, I've not seen any reactions that I would classify as allergic. I have seen one reaction to the Pfizer vaccine that I do believe was allergic in nature, but that particular patient did not have any of these risk factors. If you are allergic to a substance called polyethylene glycol, which is the main component in Miralax, which is a laxative, you should not get the mRNA vaccines. This is a very rare allergy. And if you're allergic to polysorbate, which is also a very rare allergy, you should not get the Johnson & Johnson vaccine. These are the components we think in each of these vaccines that would lead to a possible allergic reaction. Next slide. So common vaccine side effects are local, like with any injection. Also, you can have systemic effects, fatigue, headache, and muscle pain being the most common. These tend to last about 24 to 48 hours and often treatable with anti-inflammatories or acetaminophen. Next slide. There have been some rare side effects that have been reported with some of these vaccines. Myocarditis, which is inflammation of the cardiac muscle, has been reported with both the mRNA vaccines. This typically produces chest pain and possibly shortness of breath. Laboratory evaluation will show elevated cardiac enzymes as well as EKG abnormalities. It's usually a very mild disease and usually does not lead to any long-term effects. It mostly affects young males. About 1 out of every 100,000 vaccinations can result in myocarditis. On the flip side, if you're infected with COVID-19, you also have a risk of developing myocarditis. And in fact, 1 to 2 out of every 100 infections with COVID-19 will develop myocarditis. So this is likely thought to be secondary to an inflammatory or immune response to the spike protein that we see both with the vaccine as well as natural infection, but much more common with infection than it is with vaccinations. So it's still recommended that you should get vaccinated if the mRNA vaccine is right for you. Next slide. Blood clots have been reported with the viral vector vaccines, both Johnson & Johnson and AstraZeneca. It produces a syndrome similar to what we see in something called heparin-induced thrombocytopenia. This is a sensitivity to a blood thinner called heparin that leads to low levels of platelets that causes blood clotting. There's been a report, there have been 12 females who were young. They were affected by a very specific type of blood clot called cerebral venous sinus thrombosis. It's led to 3 deaths. This is not a typical kind of stroke. It often causes a headache, which can be severe, and it can cause herniation of the brain and the spinal column, which is how it results in death. It's estimated that as far as blood clots go, there's 4 to 5 cases per million vaccinated, but there's also been blood clots associated with actual infection with SARS-CoV-2. It's estimated to be about 39 cases per million infections. And we are now starting to see an increased risk of stroke and heart attacks that occur approximately 6 months after a natural COVID-19 infection. Next slide. Menstruation anomalies have also been reported. This can be heavier menstruation, skipped menstrual cycles, or just irregular menstrual cycles. This is thought to occur in about 0.5% versus actually 25% of women who've been infected with COVID-19 that report these menstruation anomalies. And this is not something that's unique to COVID-19. This is associated with both the vaccine as well as infection with influenza. This does not lead to any long-term abnormalities, and we've known about this side effect with these infections with vaccines for some time now. Next slide. And so I get asked questions all the time. If I get vaccinated, will I become infertile? And the answer is no. And so this comes from a German epidemiologist who speculated that there was some similarity between a placental protein and the spike protein. But in fact, these two proteins share almost none of the same genetic code. They're not similar. It has not been shown that the virus can bind to this particular placental protein, and it's not been shown that the antibodies that you made to the vaccine or to the virus itself would prevent any sort of fetal attachment to the placenta. So this is a complete myth. In the Pfizer mRNA vaccine trials, in fact, 2 women in the vaccine arm became pregnant during the trial. There was 1 miscarriage, but that was in the placebo arm. Next slide. So variants have been in the news a lot, especially the Delta variant, which is now the most common variant causing infection in the United States. All viruses mutate. SARS-CoV-2 is actually a lot more stable than other viruses, for instance, like influenza, which mutates constantly, which is why the vaccine has to be remanufactured every year. But it looks like with vaccines for SARS-CoV-2, the manufacturers of this did a lot of research in looking at both T cell and B cell immunity. And there's actually a very robust T cell immunity, which is quite promising for long-term immunity. And all vaccines so far seem to confer protection from all variants, including the Delta variant. And so why is this? Well, looking at T cells, they've developed actually antibodies and antiviral abilities towards 52 epitopes or areas of the spike protein. And these variants usually result in just a single mutation of one of these epitopes. So even if you were to become or exposed to one of these variants, including the Delta variant, you still should have immunity to 50 or 51 of these epitopes, which would prevent the infection. Or if you did get infected, you likely would have very mild or even asymptomatic disease. And so T cells are very important in your immunity and long-term immunity to this virus. Next slide. So what are the long-term implications of this? So this is a slide, shows a picture from the 1918 Flu Influenza Pandemic, sometimes called the Spanish flu. So this pandemic happened at the end of World War I, and soldiers returning to their respective countries brought this virus back with them from Europe. It resulted in 50 million deaths worldwide, 675,000 of which were in the United States. This is a study out of Nature, which showed they looked at people who had survived this pandemic 90 years later, and they still were making neutralizing antibodies against that influenza variant. So these antibody responses can be very long-term. Next slide. So, and what we're looking at here, germinal centers are really a key to a persistent and protective immune response. Now, germinal center is an area inside your lymphocyte where your B cells continue to replicate and continue to make antibody production. This is also where B cells are changed into what we call memory B cells, which confer long-term immunity. This is a small study of 14 patients who both had been fully vaccinated with the Pfizer vaccines, and so we think this also confers to the Moderna mRNA vaccine. But all of these patients were still having a very robust antibody production when they looked at germinal centers 4 months after the vaccination. So this might actually confer long-term immunity if you've been fully vaccinated with one of these mRNA vaccines, and you probably will have antibodies for many, many years and likely will not require booster vaccines in the future. Pfizer has recently petitioned the FDA to release a booster vaccine where they've manipulated the mRNA to reflect the Delta variant. But likely if you've already gotten just the original mRNA vaccines, you probably wouldn't need that booster either. Next slide. So I wanted to thank everyone for inviting me, especially Holly and Janine for helping me with the technical aspects of all this, but everyone on the board for having me back to do this talk. Next slide. And that's my son, Lewis, who has 18P minus. He inspires me every day with his enthusiasm for life and the way he meets all challenges that come his way. And so I think this will conclude my talk. My family and I have really enjoyed being a part of the registry. I think this is a wonderful resource for information, and the data that you guys share has been really helpful for all of us, and it's nice to commune with other people with 18 abnormalities. Thank you.
Awesome. Well, thank you so much, Dr. Paul. Lewis is so adorable. I love seeing him in your video that you did with us earlier this year. And thank you so much for that presentation. We got a lot of questions, so if it's okay with you, I'll go ahead and just read them as they came in, and we'll try to get to as many as we can. If we're not able to get to all of them, I'll reach out to you later and then be able to get back with the person who asked the question. So we'll go ahead and get started. The first question came from Camilla, and she asked, myself and my 15-year-old son are fully vaccinated with Pfizer. Lillian, 19 years old with 18P minus, has a needle phobia and does not want to get the vaccine due to this. She says she's waiting until it's available in another form, like a non-shot. Do you see that ever happening, a nasal spray or something else?
I don't. Currently, all vaccines that have been developed are injections. The virus can cause GI symptoms, but I've not heard of any oral vaccines being developed. And the previous nasal vaccine that we had for influenza is not currently recommended to be given anymore because it did cause, it causes a subacute infection in most people, but it did cause some problems by actually causing infections in people. And so it's mainly recommended to get the injection even for influenza.
Got it. All right, a question from Dalton. Is there some special care we need to have for our chromosome 18 because of COVID? Are they less resistant to the virus?
No, just because there's a chromosome 18 abnormality does not mean that they're at increased risk for infection or more severe disease. Certainly if there's an immune deficiency, that's something to consider. And so immune deficiency would be at increased risk. And as we've seen in some of the previous talks I've had, there are a lot of immune deficiencies that's present in this particular group of patients.
Got it. All right. We have a question from Natalia. How many negative antibody tests suffice to rule out definitively one did not have COVID if one had BCG vaccine in Europe as a child?
So I can't give you a number of the tests. The tests that I have that's available to me doesn't even tell us how high the antibody response is. It just tells us whether it's positive or negative. If you do have a persistent negative test, you probably do not have antibodies, though, against this. And the BCG vaccine would not interfere with that testing.
Oh. All right. Question from Mrna. Once there will finally be a vaccination for small children, we want to vaccinate our daughter that uses a weak cortisone cream twice a week for her eczema. How long before and after do we need to stop this so the immunization can happen properly?
You shouldn't have to stop a topical steroid. That would be okay to continue using that. That won't interfere with your immune response systemically. And then the pediatric trials are ongoing. And I suspect that it will be available at least down to 6 years old fairly soon. So far, it looks like these vaccines are very effective in children, and they're just as safe as they were in the adult trials.
Wow, all right. A question from Liz. Flu tends to put Charlotte into the hospital due to the inflammatory response she has to the virus. Do we think she would have a similar reaction to COVID? I know they are different, but can a reaction to one be predictive of how they could react to another?
I've not heard anyone comparing anything like that between the two infections, but that is what leads to more severe disease is it's a level of inflammation. And those comorbid risk factors, including severe obesity, is an inflammatory state. And if you're already in an inflammatory state and you contract this virus, you are at increased risk for a more severe infection than if you don't have those. So I hope that answers that question.
Got it. And Liz, go ahead and type that in. If you have more questions, we'll try to get to it at the end. Let's see. Is immunity transmissible over generations? If certain transmission can be inherited like syphilis, can immunity be as well?
No. For you to become immune to something, your immune system, if it's going to generate long-term immunity, your immune system has to be exposed to it, either through the infection or vaccine form. So, for instance, some of our antibody deficient and other immune deficient patients can't make antibodies, and so we give them IgG. We give them antibodies that are donated in plasma from other people. So we give them passive immunity, but this immunity doesn't last very long. And these IgG antibodies that are transferred from other people have a relatively short half-life. So if you're going to have long-term immunity, your immune system has to actually see, in this case, the spike protein on the surface of this virus. All right.
I think we're all learning so much. All right. Another question from Liz. Have you seen success with vaccines in your immunocompromised population? Are the mRNA vaccines working with COVID patients?
Yes, they are working. So I recommended all my antibody deficient patients, including those on IgG replacement, to go ahead and get vaccinated with either the mRNA vaccines. Most of them have done so. And of the ones who have come back and asked me to check their antibody response, so far 100% of them have responded to this vaccine. So it appears to be effective. They do give them immunity even in the setting of immune deficiency.
Got it. All right, a question from Christine. Her daughter, Kayla, ring 18, she's 9 years old, has thyroid, high blood pressure, diabetic. I have withdrawn her from school due to COVID. Am I overreacting?
How old did you say?
9 years old.
9 years. I don't think anyone should be blamed for overreacting to anything. This virus has been unpredictable from the beginning, and it is hard to predict who's going to have a more severe outcome. So of the things that you mentioned, diabetes and hypertension would be the ones that would put her at increased risk to have a problem, not so much the thyroid disorder. But no, I don't think you're overreacting. It's a matter of you doing what you think you do to stay safe. And I would encourage you to have the vaccination once it's approved for that age group. And that should make you feel more at ease to allow the child to attend school in person.
Awesome. All right. From Camilla, what test is done to know if someone has an antibody deficiency?
So generally, antibody deficient patients get recurrent infections. So we see recurrent or chronic sinus, bronchitis, pneumonia, ear infections as well. So in that setting, the test that we do is we measure antibody levels. So we measure total levels of antibodies, which the immune system makes different types of antibodies, IgG. So if your IgG total level is low, you are at increased risk for respiratory infections. IgM and IgA are other antibodies that we make. IgM is made early on in infection, and IgA is important in what we call mucosal immunity in the mouth and in the gut. Those two, you can have low levels of those and not necessarily have recurrent infections if you have adequate levels of IgG. In addition to those tests, we can measure IgG subclasses. There are 4 subclasses of IgG, and especially a deficiency in subclass 1 and 2, possibly 3 too, could also lead you to have an antibody deficiency. And there are some people with immune deficiencies that have normal levels of total antibodies as well as the IgG subclasses. They're just not able to respond to specific types of infections, and we call this specific antibody deficiency. So although their total levels look normal, they are unable to respond to what's called polysaccharide antigens. This is most commonly found on a particular type of bacteria. That's a strep bacteria called Streptococcus pneumoniae or pneumococcus. It's the most common cause of ear infections, sinus infections, and pneumonia. It's also, the antigens also found on a similar type of bacteria called Haemophilus influenza, which also causes these similar kinds of infections. So hopefully that answers your question. So when I assess someone for an antibody deficiency, I measure all of those things, and then I challenge them with the polysaccharide vaccine for pneumococcus. In a month, I'll go back and measure their antibody levels to see did they respond to that particular vaccine to verify that they could. If they cannot, that does define an antibody deficiency.
All right. Let's see, a question from Stephen. How can you detect side effects with kiddos that can't communicate and possibly experience pain that we don't?
Well, I don't know that you can, but fortunately, most of these side effects are quite mild in nature. And if in that setting, you know, it's not necessarily recommended that we go ahead and pre-treat with anti-inflammatories like ibuprofen, but that might not be a bad idea. And we don't think that anti-inflammatories would prevent a robust immune response to the vaccines either, but it would prevent some of the achiness and headaches that come along as side effects. Got it.
All right, a question from Liz. Why are vaccines more effective than even natural immunity post-infection?
Well, the answer to that is that we don't know. And because the virus is relatively new, we don't have long-term data on what kind of antibody responses are made to natural infection, how long they do last for. Especially though, it probably would depend on how severe of an infection that you had. Severity of infection would probably confer with viral burden, and the more virus that you are exposed to, probably the more antibodies that you would make. And so if you had a very mild infection with COVID-19, you may not have as plentiful antibodies against the virus as you would if you had a more severe. So we just don't have that data yet, and that's just going to be something that is going to take time for that to develop. But it is possible that people who are infected will have long-term immunity just like those who are vaccinated.
All right. A question from Marita. Any statistics about 18th chromosome vaccine?
Are you talking about the COVID-19 vaccine in the setting of chromosome 18 abnormalities?
Let me see if she'll answer. Marita, will you go ahead and answer in the session chat?
If that's the case, no, there's done on this specific population. Of the people with chromosome 18 abnormalities that I know of that have been vaccinated, they did just fine.
Okay, And we'll get back to that if she responds. Let's see. Everybody says your son is so cute. Love the grin. Super cute boy. Question from Chris. How can we tell if our child has an immunodeficiency? Oh,
Well,
an autoimmune deficiency, excuse me.
So I think there's immune deficiency, there's autoimmune disease. And in fact, people with specific types of antibody deficiencies are more at risk to have autoimmune disease. So symptoms of immune deficiency would be recurrent infections predominantly, autoimmunity in a very specific way, depending on what your immune system is specifically attacking in you. And so that can have any kind of symptoms. I mean, for people with autoimmune thyroid disease, they'll have symptoms of either overactive or underactive thyroid disease. But that really is dependent on what it's affecting. If it's something like a lupus or rheumatoid arthritis, it'll be joint pain and redness and swelling of the joints, things like that.
All right. From Marlene, can you test for PEG and polysorbate allergies?
So PEG would be easier because that's available in Miralax. So that could be tested through a skin prick test. Yes, you could test it that way. I'm not aware of any allergy blood testing that's available for either of those two substances. Once again, these would both be very rare allergies, but likely you would have figured this out at some point by already reacting prior to getting the vaccine.
Okay, got it. From Amber, why is Pfizer creating a booster if not really needed?
Well, so so far it looks like the current mRNA vaccines we have are very capable of fighting against these variants. But one of the interesting things about mRNA technology is that the mRNA code can be manipulated fairly easily. It can be changed to reflect each of these variants and potential future mutations. So far, the mutations that we've seen with the virus have conferred changes in very little of the spike protein, but it's possible that in the future, we'll see some variants that have many changes in the spike protein where the vaccines would not be as effective. So why are they doing it? Probably because they can. And because it's being talked about in the media and on the news so much, there is a significant population who would probably want that Delta variant in their vaccine.
Got it. And lots of thank yous. From Dalton, do you have some information about CoronaVac, one of the vaccines we use in Brazil?
I'm aware of that vaccine, but I am sorry, I did not have time to do much research on it.
Got it. Thank you. Wonderful talk, great info. Thank you for sharing. Does anyone have any other questions they'd like to type in the chat, or they can go ahead and unmute themselves and ask Dr. Paul? We really appreciate you answering all of these questions. You had so much amazing information for us. We really appreciate it.
Happy to do it. Thank you.
Everybody's still saying thank you. Thank you for great presentation. We deeply appreciate your time.
Dr. Paul, do you think that they would possibly ever, with that Pfizer Delta, do you think they'd approve it for higher risk individuals, whether it be the elderly or the immunocompromised, where potentially having a booster like that might be, could that be sort of one of the inspirations behind Pfizer's work is?
Absolutely, yes, absolutely. And like I said, there is a population who's going to want that. And that should be the population that would want that, those who are at higher risk for severe outcome. So yeah, good question.
Thank you so much. You totally described my daughter's immune issue, totally. Yeah, because the whole pneumococcal thing and flu and very high, but she gets normal. She has normal IgG levels. Sometimes even in our troughs, she can have over 1,000 IgG, but yet she'll have chronic sinusitis, and we have to do full IgG therapy, even though her numbers look good. And luckily, our doctor says I treat the patient, not the numbers. So
yeah, absolutely, and that's how the approach should be. Antibody deficiency is a very wide spectrum of disease. So that's exactly what you're describing.
Which is such a shame when some people have trouble getting a diagnosis and getting treatment because they're only looking at numbers.
Right.
Hi, Dr. Paul. I put a quick question out there, and it's just kind of like, what are your thoughts about like young children under 5 getting the vaccine, like risk versus reward?
Of course, children tend to have better outcomes than the older population, and we know that. But they can have a bad outcome with infection. That's a possibility. And of course, children can spread the virus to someone who is more susceptible to a severe infection. And so I think the vaccine will be available probably down to 2 years old at some point. Generally, the way they do these, it's usually around the 5 or 6 year old population first, and then they'll do the 2 to 5 year old population. But they might even come out with a younger vaccine sooner than that. We'll see.
Okay. Also, do you have any knowledge around like when like vaccines will go to full authorization because they're under emergency use? Is it really like the long-term study and the data that is like driving that?
Yes, that's just going to take time.
Okay. Thank you.
Yes, you're welcome. Thank you.
Great questions, Janine. Does anyone else have a question? We have 3 more minutes.
I just want to say thank you so much. Your knowledge about this subject coming from an immunocompromised household is like fabulous. You totally speak our language. And we're very excited. And actually I had one, so this will be, can our kids theoretically, if they have an immunocompromised, if they're immunocompromised as children, is there any chance this is going to change? Or is it because if it's derived because of their genetic issue, it's not going to, their outcome might not change? They theoretically really can't grow out of this, can they?
Well, in some cases they can. And that happens more commonly with specific antibody deficiency and with some of the IgG subclass deficiencies. So sometimes that's a temporary kind of problem. So generally, I have the discussion with the parents at some point about continuing therapy versus discontinuing therapy. It's always a hard decision to make. Generally, if we discontinue IgG replacement and the antibody deficiency is still there, they tend to start getting sick again around 3 to 4 months after their last infusion. And that's generally when I'll start measuring antibodies again. But really, you can have antibodies from an IgG infusion 6 to 8 months after your last infusion.
Okay, interesting. But I mean, so would you recommend like trials like at 18? I mean, is it something like, would you do a trial stop every couple of years, or is it something like every 10 year kind of thing?
Well, it's an individualized decision between the immunologist and the parent. You know, the first question when I start someone on IgG replacement is this going to be for the rest of our lives? And the answer is that we don't know at that point. So usually, when we get it approved, insurance will usually give us at least a year. And so at the end of that year, we tend to have this discussion. Should we go ahead and stop IgG at this time? And I'll tell you, most of my parents and patients don't want to stop because they remember how sick they were before they started the infusions, and they've seen how well they've done and how the infusions do prevent these infections. In some cases, though, I do have parents that just want to see if getting IgG replacement. And in those cases, we just kind of take a wait and see kind of approach. If they start getting sick again and requiring antibiotics, I go ahead and measure antibody levels. But generally, I usually start doing that about 3 to 4 months after stopping the infusions, and I'll do it again at 6 months stopping the infusions.
Thank you. There was one last question from a self-advocate. I have ring 18, but pretty healthy considering. Am I still immunocompromised? So if somebody's not chronically ill, can they be immunocompromised? Not usually.
Yeah, not usually. Usually, if there is an immune deficiency, they are getting ill from it.
You're probably good, Sarah. Well,
Yes.
Thank you so much.
You're welcome.
Thank you so much, Dr. Paul, for all of your knowledge, for answering all of these questions. We really appreciate your time.
You're welcome. Thank you for having me.
All right.